Hello, I'm Keith Johnston, your host for Forrester's podcast, What It Means, where we explore the latest market dynamics impacting executives and their customers. Today, we're joined by Principal Analyst Ariel Trzynski and Judy Weeder to discuss medical deserts. What are they, why they're spreading, and what the healthcare industry must do to reverse this unfortunate trend. Welcome, Ariel. Judy?
Thanks for having us.
Thank you so much.
So this is interesting timing, given that we're going in the predictions 2024, because you guys had a prediction basically stating that medical deserts will cover 85% of the landscape. And there was some evidence that you cited in that prediction, which hospital closures, insurance provider disputes, and just other factors, within the overall, medical system that's creating these deserts throughout the United States. So here we are. Like this is a trending thing that I feel like you guys are going to be studying for a while and try to get fixed. So before we get kicked off, Ariel, maybe you can just tell us what exactly is a medical desert?
Great question. A medical desert, the way that we define it, is a geographical area that has a significant lack of essential healthcare services. And so ultimately it makes it hard, right, for those residents within those different communities to be able to go and get the care that they need. And that could take the shape of prescriptions. It can take the shape of getting preventative care. It can be, urgent or emergent care, for instance. And so it really spans the full spectrum of care needs. And so, when we talk about these medical deserts, originally within the prediction, we had that really laser focused, definition around the geographical area. And it was more focused on provider shortages and some of the confluence of factors that we saw unfolding. What's interesting and what I'd love to talk more about as we dig in here is how that's evolved over time. And we've seen this evolution of other factors continuing to exacerbate this issue over the last year.
I find this interesting because I know when people hear about this, they're going to say, how is this possible in the United States? So, is it truly about geography? It sounds like there's a lot of inputs, but when I immediately thought about it, I was like, well, that's because they're just too far away. That may be one factor, but it's not the only factor. So is this just in rural areas or is this all over the country?
It's all over. And I think that the challenge that we're seeing right now, because that is intuitive, right? It's only going to happen in the far out places, the places that are super, super far away from a big city. But we're seeing it happening in urban areas too. I live in Eastern Massachusetts, and right now we are very, very concerned about the collapse of the Steward healthcare system, which is not just affecting the Commonwealth of Massachusetts, it's affecting 9 states. So you have the Pittsburgh area and the Boston area right now, currently just 2 of the cities that are in the crosshairs of possibly losing a whole bunch of hospitals. So that's a challenge when we look at that and we see that that's happening in very urban spaces where hospitals are closing down due to financial difficulties, where they're closing units. In upstate New York in particular, Ariel and I have been following this for the last several months. There have been a lot of fights breaking out between health systems and insurers. And just recently I saw a headline that said that one health system in upstate has decided that they're not going to accept United Healthcare or Humana. So that's the lion's share of the Medicare Advantage market just gone, that can't access affordable care in that area. And it's not like you'd say, well, upstate's the middle of nowhere. It's still a really heavily populated area. So we know that it's not just happening in rural areas. And that makes the problem even more pressing and poignant because it's really widespread.
I would love to build on, Judy, what you called out there, right? And maybe make it, feel more visceral for folks, right? In terms of the Medicare Advantage space. So if you're a Medicare Advantage member, the top 3 reasons you've chosen your plan, right, is the fact that your doctor is in network, that your drugs are covered, right? And it's the cost. And so if the number one reason is that your primary care doctor, for instance, was in network, and now suddenly that primary care doctor is no longer in network mid-plan year, and this happened, April 1st of this year, you now have seniors looking at, do I keep going to my primary care doctor that I've known perhaps for decades and I trust, but I have to pay more because now they're out of network mid-plan year at no, sort of input from me, right, or choice for me. I went into, choosing this health plan with the intention of being able to stick with this doctor, and now I can't. I'm being forced, to go elsewhere because I can't afford to pay out of network prices, or I pay more, right, in order to stick with the person that I trust. And so it's having this bigger impact on not just, oh, I can't go and access the care. It's maybe you can, but maybe it's really expensive and you can't do it anymore. And so I just wanted to share that as I think sometimes folks think about it as just an affordability, question. And it's so much more complex and layered, right, than just the straight cost of going and getting care.
So let's talk about that a little bit more because it just feels really complex. But the big halo is going to be the care providers, the affordability, the insurance. Like that feels like the giant input. But are there some other things that are driving this? It can't be just the insurance providers or how we exchange money within the healthcare system.
It definitely goes beyond that. So I just saw this morning on the news that Rite Aid is contracting its network of stores enough that there may not be a Rite Aid in the state of Michigan. And so we think about these national chains that have been on the front lines and helping out with vaccinations, with some really sort of basic primary care, urgent care, and we're losing a lot of these pharmacies because they're cutting back due to cost management. And what that means is that that's yet another avenue of affordable care and accessible care that's being pulled out. So it's not just the insurers, it's not just the health system in terms of like a hospital or a doctor practice. It's also the retailers as well.
Yeah, and I know Judy, you mentioned before that's not just in the rural areas too, right? You have over a third of Chicagoans are in a prescription desert, right? So if they need routine medication, right, to manage their hypertension, cholesterol, right, the basic things that we kind of take for granted, right, to go and easily get that prescription and be able to access it, that's in Chicago, right? That a third of people can't go and get the prescription that they need to help them manage their chronic condition and just stay healthy, let alone if they get sick, right? Need antibiotics or something else more serious.
Yeah, so it's so interesting. It's easy to rationalize like, well, hospital's 100, 200 miles away and you make a choice not to go because you might not be able to get there or you just, don't want to endure the journey. But then you think about areas like Chicago where you think that everybody could be served with healthcare in this country, but they can't. And now it's leading to bad choices, I imagine, which is probably another input on stressing the system and why we're heading this direction, right?
Yeah. Some of it's bad choices, some of it's just bad health outcomes. So we look at certain areas of the country where, say, reproductive care, maternity care, OB-GYN care is being heavily restricted. And what that means is that you have people who were previously maybe like 20 to 50 miles away from a provider are now minimum 200 miles away from a provider. And depending upon how much money you have, depending upon whether or not you have a job that gives you effectively unlimited or a large amount of time off, you may not have the means to be able to deal with something on sort of an ongoing basis. But now imagine that you're in an urgent situation. How do you deal with that if there's no one nearby or if there's some kind of regulatory constraint, like a legal constraint that prevents someone from being able to treat you? So now we're getting into bad health outcomes, and bad health outcomes are bad for everybody. They're bad for the patient, they're bad for the health system, they're bad for the insurer, they're expensive, and they're just bad for human beings. We're all human beings. Every single person on this planet at some point is going to need healthcare. And so it's the most basic thing, which means we have to make it available to as many people as we can. But right now we're going through this really weird contraction. And that's, I think, creating pain all along the system. And a lot of it ends up being the consumer, the individual, the human being who's caught in the middle.
So this contraction of just the service providers within the healthcare system, that sounds like a new thing. I was going to ask, do we see this trend continuing? And is there some new things that are being introduced that's changing the conditions that may make it worse, or can we make it better?
Perhaps we can bring some bright spots into this so we can talk about making it better, right? Because it's a really hard topic, right? And it's, it can be daunting as we talk about just the size of the issue. So, as we think about what can we do to turn this trend around, right? There's a lot that we can do in terms of technology to be able to mitigate burnout, for instance, for clinicians, right? A lot of clinicians have left the profession because they're being asked to do more with less. They have to do more documentation, take on more patients, see more patients, have less time with their patients. If we're able to take some of that work off of their plates through automation, through whether it's generative AI, serving up a summary of past interactions with that patient, for instance, or past visits, we can help support them in that way. We can help augment them with some support related to the diagnosis. We're not quite there yet, but hopefully we're headed there in the future. And again, being able to take some of the work off of their plates. Documentation, we're already there with technologies today embedded within the EHR to be able to take that raw input of data and turn it into something that is intelligent and structured. It can be pushed into the format that we need to bill, for services, for instance. And so there's a lot that we can do with technology, right? As much as it can be an exacerbator of burnout, it can also be a savior, right? And help us in many ways. But we do have to do it thoughtfully in partnership with the folks that are going to be using it. And there's a lot of work to be done related to that.
I have a couple of things I want to add actually to that one. Some more possibilities, some ways that we can also improve. From the regulatory perspective, at the state level, there's sort of this patchwork of rules around how doctors are allowed to practice telemedicine. And in particular, so if I go back to the Commonwealth of Massachusetts, where I live, you are not allowed to receive care across state lines via telemedicine. So if I were to leave the state, even to go just over into to Rhode Island, just across the border, I can't then have a telemedicine visit with my doctor. I have to come back into the Commonwealth to be able to do that. Regulators can fix that by going back to where we were during the pandemic in terms of how they were lifting the restrictions around that and basically saying across the country you can do telemedicine, which would then mean that where you have doctors that do have a little bit more availability in their panel, they could pick up some of these patients who right now don't have availability that's near them. And so that would be one possibility, but the regulators have to be willing to step in and actually do that. And to a certain extent, sort of like a mixed bag, they could do that, but there's also this question of how much they're able to do in light of the Supreme Court overturning the Chevron doctrine and whether that would get challenged in court. Another possibility is that employers could be looking at the way that they're designing the benefits or the benefits that they're choosing when they're offering those to their employees. More than half of the US gets their benefits through an employer sponsored plan. So, to the extent that those employers will flex that muscle when they're talking with their health insurer and push back and say, what else can you do? How else can you make it possible for me to make sure that my employees are healthy, their families are healthy, and that they're able to live their best lives because that's how I can keep them on the job and keep them working and keep them productive. So, there are different players that could play a role in helping to make this happen that aren't necessarily the ones that everybody sort of thinks of first, because we always go to health insurers and the doctors and the hospitals first. But there are definitely other players that can be part of the solution.
It's funny, we're talking about policy. We have an election coming up. It's very interesting that you can debate policy and antitrust in many industries, but it just seems like we shouldn't be arguing over healthcare. I mean, is there any good policy things going on that could stop this trend?
Yep. I mean, potentially, right? So there are a number of efforts, that are happening One of the other, risks that we talk about in the report, is concentration risk, right? And so you see concentration risk, which is taking many different forms, and it's some work that I'm continuing to work on with all of Valente. But it's one of the aspects of concentration risk is around ownership, and so you've seen private equity come in and buy up a number of health systems and hospitals, in many cases to the detriment of the communities that they're in. And so you have folks like Senator Markey, for instance, that has the Health Over Wealth Act, right, that is being proposed to try and bring more transparency, but also some pretty robust practices that make sure that, do you have an escrow account essentially set aside for helping cover capital expenditures for a number of years, for instance? Do we have the ability to make sure that we can mitigate against the risk of closure for a period of time to ensure that we don't create a shock to the system, right, and a shock to the community when one of the largest employers and sole providers of healthcare, for instance, is suddenly at risk for closure or can't pay their bills to medical suppliers, for instance. We have to put in efforts and guardrails, right, to help mitigate that, and that comes with requirements, and it comes from policy, and it comes from laws. And so there are some efforts that are underway now to help put some of those efforts in place, but you know nothing's set yet. So we still have a lot of work to do to make sure that those guardrails are there and those protections are there for consumers and the entities across the healthcare ecosystem.
So we touched on technology a little bit, and certainly there's been some amazing advancements in medicine, with technology, and there's so many opportunities. But, one of the pieces of data that you guys put in your report was that 55% of healthcare organizations spend 10% or less on IT. And you cited cyber attacks as being, a cause of actually deaths in our system. So I feel like with all this great technology, we might have an infrastructure problem to leverage with technology. So, talk about why cyber attacks are such a risk, yet we don't seem to be investing in doing something about that.
No, it's really interesting sort of juxtaposition there, right? Around, oh, this is a problem. But we're should we do something? Exactly. And so I think there's a lot more awareness and action that's happening now, I would say, in light of a number of larger cyber attacks. So we do over the course of the last 6 months or so, I will say, on the data that we've gotten back.
Of course, we just had one a couple of days ago, right? That affected some of our medical systems.
Yeah, which is a different issue. That's an issue with just ineffective testing, candidly, right? And so, but a reminder that we're sort of, inches away from our infrastructure crumbling when we don't put in the proper, testing in place or protocols in place to ensure that things are where they need to be. It's also a really good example of evidence of concentration risk, right? Think about just the widespread issues that happen because of one vendor, right, that was supporting one operating system provider and what that did to the globe, right? Not to mention banking, healthcare, right, the different industries subsequently below it. So it is a really good, example of this is the problem when we concentrate so much power, right, for technology on one particular entity or vendor. That's true for Change Healthcare too, right? The very large cyber attack that occurred over the course of this past spring, and that was a cyber attack, right? That was a bad actor that came in and said, we're going to hold this data ransom. They were able to get in because they didn't have two-factor authentication on a server. Those are basics, right, when it comes to security. So as much as we talk about needing to have greater investment in infrastructure to bolster security, yes, absolutely. But you also have to make sure that you're doing best practice, right, as a foundation that we then have to build on in terms of bolstering security. So we do start to see more folks, I think, hyper aware of the risk and the ramifications of not putting those guardrails in place and making sure that they just do the basics right and then continue to bolster their security. Furthermore, as you see, more folks trying to use data in new ways for generative AI or for analytics, and even traditional artificial intelligence, we have a better understanding of the value of that data and the need to protect it. So We are starting to see efforts related to, IT investment and budget shifting more towards security, which is promising, but it does mean that we have to work pretty quickly. The FBI has named healthcare as a number one industry target for cyber attacks. It is the most attacked industry for, I think, 3 years running at this point. And so it's the value of the data within healthcare is tremendous. You can do, unfortunately, a lot with that information. You could open up a mortgage, not just a credit card mortgage, steal someone's identity. You can, file claims falsely, for instance. It's a really juicy target, unfortunately, that we have to protect. So a lot of work to be done within the security space. You talked about technology and just what's necessary to make sure that we can find more efficiencies, for instance. There's a lot more work that we have to do, in regard to things like generative AI, for instance. We have a lot more testing that we have to do. We have to ensure that we have the right data so we don't perpetuate bias, for instance. There's a lot of incredible value that we can get using these different technologies and emerging technologies, but there's so much work that we still have to do to prove them out, to earn the trust across the healthcare ecosystem that we can do those things, and also ensure that, candidly, our data is in good order to be able to do those things. We still struggle with a lot of work around interoperability and the ability to share data seamlessly across the ecosystem. And there's still a lot of data blocking that exists and just lack of consistency in the standard and how we share data across the ecosystem.
It's so interesting, though, right? I mean, you can't get more private, personal, or important when it comes to data than healthcare data. And we don't have enough investment. We don't have enough companies out there doing all of the right things that we should be doing with such an important data asset.
Yes, all that data is incredibly personal, incredibly private data, must be secured. And there are rules around how it must be secured. But the firms that have to secure it, if we're talking about like a hospital or a provider office, that's not what they necessarily see as their primary function. Their primary function is to deliver healthcare. And that's the mindset that they're coming from. They're also worried about their reimbursements and their margins. And we could debate till the cows come home whether or not they're getting over reimbursed or under reimbursed, depending upon the specific contract it is. But the challenge is they are often running with very thin margins, particularly at the hospital level. And what that means is they have less money to be able to invest in things like making sure that they have enough IT folks, making sure that they have a hardened network, and they have to rely on their vendors. And sometimes you have people making decisions who don't necessarily understand the full impact, the weight of the decision. So, for example, if we go back a couple of years, there was a great study that had been done by the Markup about the number of top hospitals that were using the Metapixel on their websites and were giving Meta information about their patients, things like when they had appointments, who they had appointments with, what those appointments were for, all kinds of protected data. But it was all because they were just trying to track what was going on the website, where people were going. And it's very innocuous, very normal business activity, but because they didn't fully understand the ramifications of the choices that they were making, that led to all kinds of information going to a company that one could credibly argue did not have the legal things in place to be able to handle that information and to take it in.
So this is it's a deep topic with a very large system that we're discussing here. And, we have to be able to do something about it. So if I was to ask you guys, like, how might each of the players that are part of this system address something maybe here and now that can start to reverse this trend a little bit?
I'll take, a couple parts of the ecosystem, and then I would love for you to jump in on the other parts. But the first one that comes to mind for me are providers, right? They're just the core part of delivering the care. And we have to make sure that the experiences that we offer up to consumers, that they are inviting, they're accessible, they're easy, they're seamless, right? How do you make sure that you remove as many barriers as possible to ensure that consumer can get to the care that they need to? They're already facing a lot of headwinds. And so anything you can do to make this easier absolutely, welcome for the consumer. The other thing I would add, more on the technology space of this is, for providers, but also for others across the ecosystem, is to start making those investments now if you're not already, or look at how you can optimize them to make sure that you're thinking about what are the key use cases where I should be using generative AI, not just for the sake of using it, right? But where is it going to add the most value? Where is it going to take work off of people's plates so that we can combat not only clinician burnout, but we have shortages of nurses, for instance, that are looming, 5, 10 years from now. We're maybe not talking as much about physician burnout, but nurses will very much still face that critical shortage. And so we have to think about how do we start to build more of the workforce or extend them in new ways through automation and help support them in those ways. And so technology can be a really powerful tool, but again, has to be done in partnership with the folks that are using it and working with them, not against them or to replace them. Judy, what else would you add?
Yeah, so I would say for retailers, I know there's been a lot of optimization, shall we say, of their overall footprint and even within individual stores, what they're offering. I would strongly urge them to look at where these deserts are occurring and see how they're contributing to them and how they're not. I was speaking with one retailer last week who was telling me that they're actually looking at where their removal of a store would create a desert, and that's actually a factor in keeping a store. And I think that's a really important way of thinking about it. And then even optimizing the footprint, optimizing their workforce within that footprint so that you don't have just that one pharmacist who's filling prescriptions, providing advice, and doing vaccines. People only have two hands. They can really only do one thing at a time. Make sure that you're putting enough people in your stores to be able to support all the stuff that needs to get done. And then, payers, I hope that you don't think I was going to let you off the hook here. There's a really important piece here, which is the two dirtiest words in the healthcare system right now: prior authorization. It is causing so much trouble in the system to the point where we see that there are payers that are losing their contracts, that they're being booted out of healthcare systems because their rules are too Byzantine, too hard to deal with, and they've just become too complicated and time consuming and expensive for a hospital system or a provider network. So here's the thing: look at that and see what you can do to fix it. Make yours easier. Don't wait for the regulators to tell you how you should be doing it. And you can do the research by going out and doing qualitative studies or even quantitative studies. Try to understand what you can do to modify your processes that won't compromise the integrity of the decisions you need to make. So they're still based upon what's medically appropriate, but without creating so much burden that you have one of these fights that frankly catches these poor consumers in the middle and leaves them without access to healthcare. So everybody needs to get into the pool. Everybody needs to be part of this solution because everybody was part of making the problem. So whether we're talking about payers, providers, retailers, regulators, pharmacy firms, employers, everybody needs to be part of this solution. And then we can actually fix it.
Thank you both for this incredible conversation on such an important issue.
Thanks so much for having us.
Thank you, Keith. Really enjoyed the conversation.
If you like what you heard today, subscribe to Forrester's What It Means podcast on Apple Podcasts, Spotify, or your favorite podcast player. To continue the conversation, follow Forrester on LinkedIn or drop us a note at podcast@forrester.com. Thanks for listening.